There is history of bedwetting for which he was taken to a private doctor and where he was catheterized. Subsequently, 1.5 months back, he underwent some transurethral procedure, and after which catheter was removed, but he has no relief of his urinary symptoms. So he was catheterized again and is still catheterized. The tingling and numbness in the tingling in the left upper limb and lower limb since the last 1 month. Tingling started in the fingers first and has now progressed to the shoulder. Tingling is not associated with any weakness in the upper or lower limb or radiating pain. Tingling does not increase with coughing or sneezing. There is no history of trauma. There is no history of fever, weight loss, or anorexia. There is no history of any other joint involvement or morning stiffness. There is no history.
Why is that important? Other joint and morning stiffness. You are thinking in terms of rheumatoid, is it?
Rheumatoid or ankylosing spondylitis.
Ankylosing in this age.
Then on family history, there are no similar complaints in the family. Past history, he has been operated for some transurethral procedure 1.5 months back. He is not a known diabetic or hypertensive. There is no history of COX or COX contact. Personal history, sleep and appetite are normal. Bowel function is normal. Bladder is catheterized. In general examination, patient is...
Okay, wait. So history is over. So you all may be thinking, why didn't I stop him? Normally you stop him. It is because he is speaking very lucidly and confidently. So I had no point where I needed to stop him. If he stumbled, I would have stopped him.
He didn't allow us to interfere in between. So I think it was a wonderful presentation which he did.
This is you should have this sort of confidence. So this is good. Now a few things. What about, you said he has one-sided paresthesia. Right. So you need to say that paresthesia, tingling. Does he? What about the other side? Like the left? You are saying right-sided?
Left-sided.
Left-sided. And the right side?
No, he does not have any paresthesia.
There is no history on the right side. Does he have any weakness?
No, he does not give any history of...
Does he have any difficulty in walking?
No.
Alteration of gait?
No.
Alteration of fine function of the hands?
On history, he is not giving any complaints of difficulty in walking or doing any fine movements.
So did you ask about the difficulty in fine function?
Yes, I have asked him, but he says there is no problem.
Fine. So this you should have mentioned in your history as a negative history or positive or negative history. So I'll tell you why. You are thinking, see, this is definitely not a urology case unless you come on the wrong day. And so this is going to be, this is not a hip or a pediatric case. This is definitely a spine case, right? At the end of the day. So you, in spine, what can it be? What can it be? Now considering that you have said upper limb, lower limb, you are looking at something in the cervical, right? So you need to talk about other positive or negative histories which will contribute towards that. So the opposite side is very important. Right now it's looking as if you're talking about a hemi.
At the moment, the diagnosis is something in the brain which is not concerned
exactly.
with us.
You are not able to.
So you have to specifically mention about opposite side symptoms. Then probably you are coming back to cervical spine.
So opposite as well as motor. The other thing is about the bladder. You need to have some slightly more clarity about the bladder, because what is it that he has? When you say incontinence, the incontinence can be various things. Is it that he is not able to appreciate a sensation of filling and then dribbles, which is to go into the details already, because since would be like a sensory paralytic bladder. Is it that his bladder keeps emptying by itself from time to time, which is an automatic bladder? Or is it that his bladder fills, he gets a lot of pain but he's unable to void, which is a motor paralytic bladder? So all of these three have different sort of things, and you need to be able to say which of this it is.
He does not have bladder sensation and he can't void, and the bladder gets voided automatically after complete filling. For first he had...
so overflow dribbling. So he's got motor and sensory paralytic bladder.
So after all this presentation, what is the diagnosis? Because the thing which has to fit in with all these things which you have mentioned. So what is the diagnosis now?
So on history, I am thinking of a cervical lesion which could be a compressive lesion.
So which cervical lesion will give you only one-sided problem?
So it could be in his age group a degenerative disc on the left side.
Which will give upper extremity and lower extremity. So it is a spinal cord problem, no?
Yes.
One side is spinal cord.
Why can't it be CA prostate with metastasis?
So he is not giving any history of any lumbar pain or which, and the CA prostate will first metastasize the lumbar area from the external plexus.
Has he said any pain whatsoever?
No, he does
You have not said any pain. So his only symptoms are tingling, numbness on one side and back. So started with bladder,
Yeah.
tingling, numbness, no gait anomaly. So you are saying this is a cervical cord issue.
Yes.
Okay. So what sort of cervical cord? Is it compressive or non-compressive?
It on his
The jerk surface
the just surface.
only on one side.
No bilateral.
Exactly. So now you are coming that there is probably bilateral problem. When you started off the things you didn't talk about.
What is it?
You said the jerks are they are examination.
On history, he is giving symptoms only of bladder and one-sided tingling. Hand and leg.
So I would say this is a difficult case. I would say that this seems to be a case of neurogenic. So it's the difficult case, to be fair. What I would say, it's a case of neurogenic bladder, secondary to probably neural involvement at the cervical spine or above. But I would be able to give further details after my examination. I think that would be. It's like a because you cannot say
Central nervous system. You should mention something.
higher functions. Yeah, so higher functions you need to also talk about in the
History.
history as well.
Probably
Slurring of speech.
I would have gone, though the symptoms are only one-sided, but he has the jerks which are brisk on both the sides without any symptoms on the opposite side. So you are only trying to come down to as a purely cervical spine.
No, it's not hypertensive.
So he mentioned. So even diabetes he mentioned. So that's okay. Go ahead.
On general examination, patient is averagely built and averagely nourished. All the vital parameters are within normal limits. There is no pallor, clubbing, icterus, cyanosis or lymphadenopathy. There are no scars, sinuses or swellings. There is no gross wasting in the upper or lower limbs. On local examination, patient is conscious, cooperative, well oriented in time, place, person and has normal higher functions. First, I would like to describe the gait of the patient. Yes, you can. चालून दाखवतो का थोडं?
Can you describe the gait?
He has a painless, bipedal, unassisted, short step gait.
मला कुठल्या बाजूला दुखतं? खाली डाव्या बाजूला? या बाजूला सुद्धा दुखतं? काही नाही, फक्त डाव्या बाजूला. आणि हाताला एकच हाताला. त्या हाताला काहीच नाही.
तुम्हाला चालायला काही त्रास नाही होत का? हवं तेवढं चालू शकता, धावू शकता, पळू शकता आणि हाताने काय काम करायला काय त्रास होतो? काय हातातून जेवण पडतं किंवा काय पडतं? काहीच त्रास होत नाही. हाताने सगळं जे काय करू शकतं. बटन लावायला वगैरे जमतं तुम्हाला?
चप्पल निघून जातं याचं काय होतं? काहीच नाही.
बसा बसा.
बॅग आहे अंदर पकड.
Because he's clearly he's not coming up with it.
We try to reconfirm what you say, but it's not true.
The same thing that your observation and whole उसके बाद history presentation. You can't say that he didn't say so. I will just translate and say.
Okay, come to neurological examination.
Neurological examination, first motor
Yeah,
function.
quite a lot of people spend a lot of time in general examination. Even in a short case, in a long case, you have a limited time in which you have to finish the whole thing. So don't spend too much of time in general examination unless there is any specific point which you say, or a specific negative point which you say.
Motor examination, first muscle bulk. Muscle bulk is bilaterally equal, there is no wasting. Tone, there is spasticity in all four limbs. Power is grade 5 in all for upper and lower limbs. In coordination is normal, and there are no
How have you measured the waist?
Sir, in lower limbs from ASI is 15 centimeters in the mid muscle bulk when compared with bilateral.
You have measuring it, but you didn't make any markings. So you have to mark the equal points on both sides. That's what I'm saying. These are cosmetic
Yeah, I
things.
have good memory, sir. Every time I go down to 6 centimeters, I remember that.
Okay. So no wasting.
So you're doing well. In spite of all these things we are doing it, you are at the moment you are going to pass. So please proceed properly.
Reflexes. First deep tendon
One
reflex.
second. Reflexes come next.
Sensory.
No. First is motor. Motor. Motor में क्या क्या आता है?
Motor, bulk, muscle bulk, tone, power, coordination, and
So you haven't.
power is grade 5 in all four limbs.
Okay.
There is no involuntary movements and coordination is normal.
Is it? So just show me coordination. How will you demonstrate?
Power. First, I would like to demonstrate this dialogokinesis. असा alternate कर पटापट. And finger nose test. हाथी पेट लो. दुसऱ्या हाताने कर. हे असं करतं. दुसऱ्या हाताने कर. आता हा हात कर. He is slightly sluggish with the left hand. On that side.
I think he has thinner waisting.
लाउडो क्या कर रहा है उसको बैठने देना
It's on both the sides.
हॉफमैन कर रहे देखा दिस थिंग संदीप पर put them so that's
So
a
he has grip
Hoffman
weakness. He has got wasting. He's got wasting in the web spaces and coordination. Can you tell me?
Hoffman and grip
Are you done with coordination?
No. Finger nose test.
Okay. Then what else?
Then tandem gait for lower.
Lower limb. How will you see?
Tandem gait.
No. Lie down. So zopa sir.
Finger nose and finger finger. Yes.
So the coordination is you have to ask him to touch his heel to the opposite knee and take it down and lift it up. Have you done that? So that is the main thing which will clarify that he's got lack of coordination. दादा हा जो आहे ना तुमचा
Hard. Hard.
दादा झोपा हा इकडे लावा आणि असा घेऊन परत इकडे पाय ठेवा
गुडघ्याला लावा गुडघ्याला.
गुडघ्याला हा पाय आहे ना हा इकडे गुडघ्याला लावा त्याच्यानंतर असा खाली घ्या आणि असं करून इकडे ठेवा करा.
that is heel knee test fingernail is for upper limb heel knee is for lower limb
Coordination is very important.
okay
That tone is normal. Tone.
No, there is spasticity normal.
Okay. So that's why the nutrition tone.
क्या बोल रहे power is great for
Yes.
all the four limbs जिसने बोला ना how can it be
Yes, I know, but he has to mention it as a finding. So spasticity. Can you show me spasticity? Demonstrate.
Relax. Relax. Spasticity on velocity dependent.
What are the types of rigidity?
The hypertonia is divided into spasticity and rigidity. Spasticity can be class knife, which is a pyramidal lesion and involves either one group of muscles, gravity or anti-gravity. And the rigidity can be class knife or lead pipe rigidity or cogwheel
Lead
rigidity,
pipe or
which is
cogwheel.
extrapyramidal symptom, and there is both gravity and anti-gravity, and there is.
So you need to know class 9, lead pipe and cogwheel. Good. So your motor power also we don't agree with your finding. Your spasticity you didn't mention, and the coordination we don't agree with your finding, and your wasting you did not mention. Next, then sensory.
Samir, how will you know the wasting if it is equal on both sides?
No, he's got wasting in the palms. He's got thinner wasting.
Sensory.
Yes.
Sensory examination, I have examined for fine touch, crude touch, pain, temperature, and joint position sense and stereognosis or sensory modalities.
What was the finding?
Is normal.
Can you demonstrate joint position sense?
एक मिनट.
Now, with this findings, what you got at the moment, where do you think is the lesion? There is some localization, no? At the moment, whatever the findings which we have been able to find it out, there is some localization there in cervical spine.
Since there is wasting in the, I am suspecting a lesion at C7, C8.
So there is some localization. So about the sensory findings we have been able to see, there is no sensory affection in the
Sensory,
C7.
I have not got any reduced sensation in any dermatomuscular. Joint positions. काय आहे बघा, हे मध्ये हे वर आहे आणि हे खाली आहे. झोपून घ्या, डोळे बंद करा. वर केला तर सांगा. आता कुठे आहे? वर आहे का खाली आहे? तुम्ही पाय खाली नका टाकलं. वर आहे का खाली आहे? वर. आता आता तसंच या पायाचं सांगायचं. आता
Okay, wait, one second. Right or wrong? Anyone says it's wrong? Oh, everybody says it's wrong. You. Why wrong? Okay, that's the only reason. Okay, sit down. Next, anyone?
You have to.
Multiple. So another 50%. The next last 50% over to the side. So his was 1%, 49%, 100% हो गया. समझा? So one of the things is you need to stabilize. The other thing is initially you need to confuse him slightly by doing up and down, and they need to hold at the side. When you're holding down, he knows you're pushing up. When you're holding up, he knows. So you need to hold this 1-2 times and then आता वरे की खाली है, आता वरे की खाली है. And 2 times is not enough. Multiple choice में you have to give a bit more chances. So these are all the reasons why. So it's a very small thing. In this whole thing, if I ask you to demonstrate only this, I would say not good.
And don't do it up and down in that sequence. So you try to confuse him basically.
काका डोळे बंद करा.
So again, you hold at the side.
He is going to know about the pressure in which direction you are exerting. So the interpretation is going to be completely wrong.
आता काका सांगा वर आहे का खाली आहे?
So what does joint position sense abnormal signify?
Any compression in the posterior ascending tracts.
Posterior column.
Thrombus test is normal.
वो भी कोऑर्डिनेशन के लिए है ना, सेरेब्रल का कोऑर्डिनेशन.
Posterior column also.
नाही सर, आताच बरं पुढे या थोडं. पायाजवळ पाय जोडायचा, डोळे बंद करायचे.
Cerebellar रहेगा तो he'll sway, invariably sway. इसमें कैसा है तो आंखें बंद करें तो he'll sway ऐसा.
Okay, you fall this one. Anyway, next, what else can you do? Reflexes?
Reflexes.
So, demonstrate the reflexes.
दोनों स्पीचन क्या
Posting घालायचं. त्या साईडला जो पाय टाका.
Yeah, I mean, superposition, deep tendon reflexes. Hoffman's is specific with a special test sort of.
First, deep tendon reflexes of upper leg.
प्रॉब्लम्स की से ना हॉपन से कुछ
Main thing biceps, brachialis, triceps पूछेगा.
Relaxed.
And ये नीचे का superficial reflexes and deep tendon reflexes.
Relaxed.
वो important.
हाथ पहला
Okay.
biceps is exaggerated.
So you can say that I can answer this question when I've examined the rest of the patient. Because you one isolated reflex, you should be able to compare it to the other reflexes, if you want. So you demonstrate everything.
Relax down. Relax. Close down. सोडून द्या बॉटल. सोडून द्या.
Okay, you're gripping his forearm too tight. But what is the reflex? What is this reflex?
Reverse supinator reflex. Inverse brachioradialis.
Okay. Fine. Show me the Hoffman sign.
तुम्ही रिलॅक्स राहा.
Okay. Is it positive or negative?
Positive.
Describe what it means to be positive.
Positive sign is when you flick the distal phalanx, there is flexion of the other fingers first and
Thumb.
What does it signify?
it signifies a upper motor neuron lesion in the cervical spine.
Okay. And what is it actually? Like what reflex is it? Is it a superficial reflex? Is it some special test?
It's a primitive thing, no?
It's a superficial reflex?
Primitive, I think. I'm not sure.
What sort of reflex is it? Is it like a plantar or abdominal? Is it a superficial reflex? Superficial reflex are also known as cutaneous reflexes, right? So is it a deep reflex or is it a special test?
Special test.
Special test. Or is it a deep tendon reflex? Actually what you are doing is you are eliciting a deep tendon reflex from the flexor of the finger. By flicking it, you are not able to put a hammer and put there. That's what you need to understand. So Hoffman positive is a upper motor nerve and exaggerated reflex.
Deep canal.
Does he have clonus?
He has a sustained ankle.
Hold मत लेकर ना इसमें.
Please demonstrate.
North का जो है वो find out first. देखना पड़ेगा Hoffman के बारे में. ये I think it is a primitive. ये जो ये रहता ना glabella tap and something ये रहता ना.
और बाद में
एकदम रिलैक्स.
Inhibition रहता है.
ब्रेन डेवलप नहीं होता ना तो अपर मोटर न्यूरॉन काम नहीं करते. रीजन वैसा रहता है.
Yes. मेडिसिन में पढ़ा था ना. Sustained क्या?
Ankle.
Relax.
What is the difference between ill sustained clonus and clonus? Clonus is how?
Ill sustained or well sustained. If there are oscillations less than 5, then it is a ill sustained.
Show me the ankle.
Relax, John. Relax. Relax, John.
He's catching at
Show me his ankle reflex.
He's catching at the wrong place.
खाली था.
Is it how will you classify it?
I would call it brisk.
I would call it normal, but anyway, fine. Okay.
Plantars are upward.
Okay.
And abdominal reflex is present.
Present.
Yes.
So does that fit in?
No, it does not.
Go ahead. Examination.
ब्लैडर कैसा था उसका मतलब नहीं ये अभी यूएमएन में बैठेगा. इट्स यूएमएन, इट्स नॉट एलएमएन.
Compressive myelopathy and extrapyramidal.
बट लीजन किधर है? यहाँ पे ना.
So sensation also you have. Did you mention or examine the sacral dermatome?
Yes, he does not complain on any sacral sensory loss.
Okay. What else?
Then I have also examined the bilateral hip joints and he does not have any significant findings in the hip joint. Cranial nerve examination is normal and higher motor functions are
ब्लैडर के
normal.
बारे में ओवरफ्लो इनकॉन्टिनेंस है.
Doctor, tell me your diagnosis.
मींस एलएमएन है.
He is a case of cervical myelopathy in a 65-year-old male, most probably due to spondylotic cervical spine disease, currently disabled with urinary incontinence in the last 4 months. Yes, cervical spine movements, flexion is full, extension and lateral bending are restricted.
So why do you say that this is compressive? You are saying you have actually come to a diagnosis of spondylotic. You have come directly to a diagnosis of spondylotic. So that is very far away from where you are. We are still wanting to know. First, you tell me why it is cervical.
since I'm getting a reverse supinator and Hoffman sign positive, I would think of a C5, C6 lesion. Yes, sir.
So why is it cervical? Because upper and lower limbs both are involved. Within the cervical, do you have a level?
I would like to think it is a C5, C6 lesion or higher because of the reverse supinator.
So how do you explain his grip weakness?
Because
What is the root value for the grip?
C81.
So why are the grips weak?
It could be a multiple level involvement.
Okay, so that answer is wrong. The right answer is that this is the myelopathic hand. This is not that he doesn't have grip weakness because of C8 and T1 root involvement. It's a myelopathic hand where the intrinsic muscles have a misfunction and therefore they go into this. Okay. So now why do you say it's compressive?
Sir, it has been progressive in the last 4 months, and there is no other history suggestive of any tumor in the spine.
But can it be an intradural tumor?
Sir, on history, I cannot. It is more likely to be a compressive since intradural tumor will not cause tingling as a presenting complaint.
Can it be an intramedullary tumor?
Can be a
So it can't be intradural. So you are saying it can be external. It can't be intradural, but it can be intramedullary.
But for a tumor, he does not give any history of any aching pain, long-standing, and the history has been only of 4 months.
Doesn't rule out. What is if this patient? If you take this patient's history at face value, okay, that his bladder came first and everything else came later, what would be your diagnosis?
Only on history, sir,
Intradural.
bladder involvement first gives. We can think of an intramedullary tumor.
Intramedullary, right? Because the central tracts have been affected first, and the peripheral tracts. So, secondly, does he have any history of neck pain or radicular pain in the arm?
But the Samir, he had symptoms wise, he had that symptoms of the bladder. But at that time, whether the upper extremity...
No, so I asked him that if you take the symptoms at face value,
So
he has no history of neck pain and radicular pain. So how can you put cervical spondylotic as the...
So it can be a degenerative disc disease with central protrusion, which will not...
But he doesn't have any history of neck pain or radicular pain. So completely painless.
So do your findings match what he says history-wise?
No, they don't. All the findings do not match.
Does any match? So what would you rely on? His history or your findings?
My findings.
Exactly the point. Don't harp on his history. He is simply too tolerant and too kind to the patient.
So we are short on time, so we just go ahead quickly. The next, what is your, what would you like to do for this patient?
So first I would like to do cervical spine x-rays, AP and lateral view.
X-ray सिद्धना.
You will ask for the X-ray. He comes with the X-ray, then you will ask MRI. Is that so?
Yes, sir.
So you won't ask for MRI directly without X-ray?
No, sir.
What information will the X-ray give you which the MRI will not give you?
So on X-ray I would like to see for any anterior osteophytes or in the canal narrowing or reduced disc space.
How do you see that?
Ratio.
What do you mean by anterior osteophyte?
So in case of
Lateral aesthetic. Read orthopaedic for DNB.
this is the X-ray of cervical spine flexion and extension, flexion and extension views. On the lateral X-ray you can see degenerate osteophytes in the C5, C6 region, C4,
Can you see
C5.
posterior osteophytes?
So those osteophytes anteriorly, they are of no importance. Eh? It's not going to be contributing to any neurological symptoms.
Posterior osteophyte? canal ratio. Show me the canal ratio. No. So essentially the X-ray is of no value to you. Why did you ask for it? It's orthopedic exam, so first test is X-ray. Anyway, so you can see the canal in that also and the posterior.
Basically, there is no instability which is there. There is no atlantoaxial problem, or there is no spondylolisthesis at the.
So this is a posterior osteophyte. This is a posterior osteophyte. These are posterior osteophytes. This is posterior osteophyte. And the canal ratio, basically what you can see is from here to here, and the body is here to here. So this canal is less than the size of the body. So this is known as Torg's ratio. So this is a stenotic canal. So the chances of him having a cervical myelopathy are higher in a stenotic canal. Anyway, the other things you have to say is there is no erosion, there is no instability, especially at C1, C2, etc. So MRI. Would you want to do an MRI?
Yes.
And in the clinic, if he came, you would have asked in 2 stages. You would have asked for 1 stage only, no? X-ray and the MRI, because basically you and me know that MRI is going to give you information. My X-ray is going to give you only the small findings of instability and other things.
Ask for more X-rays, chest X-ray, formats.
वो इसके लिए भी ना
I think, yeah, but the orthopedic.
दूसरा image is now.
Okay.
So on the right side, we have a cervical spine MRI with a whole spine screening. There is significant cord compression at C5, C6 and C4, C5 level.
Okay, describe fast.
Then with a hyper intense signal loaded at C5, C6 level at the cord. There is significant canal narrowing at the 2 levels.
Over here, right? So I would also say that there is a reversal of lordosis. There is cord compression of the cervical cord. The cord compression is because of disc prolapse as well as possibly thickening of the posterior longitudinal ligament. अच्छा, अभी जरा इधर का दिखा, बस इधर का दिखा. Here, what is this?
That is a central collapse disc.
Right. So this is more of a what is the difference between a soft disc and a hard disc in this instance?
So hard disk is more likely to cause radicular symptoms.
No. What is a hard disk?
Desiccated.
Quick, hard disk. Anyone? One word.
Desiccated.
No. Hard disk is just a description. It's a word. A hard disk is actually osteophytes. So the osteophytes which compress the cord are known as hard disk, and the soft disk protrusions are the disc herniation. Right. What is OPLL?
Ossified posterior longitudinal.
How can you know whether this case has OPLL or not?
I think contrast.
How will you look for ossification normally?
So calcification.
How?
It will look as a
I think I
hyperintensive.
would do get contrast.
You can ask for the CT scan.
Contrast.
So now you are tired and confused. That's why. So if to differentiate OPLL from disc, I would like to do a CT scan. What is your because we're short of, we want to do one more case and I have to leave for my train. So I'm going to ask you.
Why
what
do
is
you
your-
want to differentiate between these 2 entities? OPLL and only the myelopathy which is there because of the osteophytes. Does any treatment change, a prognosis change or anything?
So you should know this answer. The answer, since he's asking yes, obviously, that OPLL is a more terrible disease. The prognosis of the outcome is worse. Surgical complications are higher, and the treatment protocol may change as to the selection of procedure. So you need to read on this basics of OPLL and cervical myelopathy. Just tell me in short the treatment for this.
The aim of treatment would be to stop the progression of the disease and to achieve any possible improvement in his current symptoms. So I would like to offer his complaint of urinary retention in contact. It won't. The chances of recovery in a cervical myelopathy, the disability is already there, are very less. But the aim would be to stop the progression of the disease. So I would like to offer him surgical cervical cord decompression and fusion.
Conservative treatment?
No sir, since the bladder is involved, surgical.
But you said the bladder is not going to recover.
But he has started developing a myelopathic hand, so I would like to. Since there is severe cord compression, it can deteriorate. His myelopathic features could worsen and he could develop instability and incoordination.
You want to do anterior surgery or posterior surgery?
Anterior surgery.
Anterior surgery. Why not posterior?
The plan is to decompress more than 3 levels, then posterior cervical decompression is preferred.
Here there are 2.5 levels.
Maximum compression at C5, C6, C4, C5. So anterior we can easily approach the C4, C5, C5, C6 level.
Okay, so this actually goes on to the higher level of discussion. Anybody for a quick answer for this? Anterior versus posterior, yes?
Posterior. The cervical spine is already into lordosis, so the anterior will correct the lordosis also. Posterior will exaggerate the lordosis.
Okay.
Compression is from anterior side to anterior.
Anyone else?
OPLL भी कर
संदीप बोलता है दोनों करो.
OPLL भी देखना पड़ेगा.
So this spine is a kyphotic spine, there is no lordosis, so therefore anterior surgery. Posterior surgery is indicated in the patient where there is kyphosis, because the principle of the surgery is a cord fallback. So when you remove it's an indirect decompression, right? You are just allowing the cord to fall back away from the anterior compression. In an elderly patient with 3 levels or more, a posterior surgery is preferred provided the lordosis is maintained or neutral. In this patient, although he has approximately 3 levels, but he doesn't have lordosis, he has a kyphosis, so we are forced to do an anterior surgery. It would be good to do a CT before surgery to see if there is an element of OPLL, to be more careful about it. And the surgery is the same, anterior discectomy or decompression with fusion. Thank you.